like to call the engine room of the human body.
That's a very apt metaphor. I like it. It's hot, it's loud, and if the machinery down there stops working, the entire ship is in very, very big trouble.
Exactly. We are talking about the adrenal glands, these two tiny, triangular little organs that sit right on top of your kidneys like little hats. And looking through the stack of research and articles we have for today, it struck me that these glands are, well, they're essentially the arbiters of our reality. They determine if you are ready to fight a bear or if you're going to collapse on the couch and not move for 3 minutes.
They really are the regulation center for stress, for metabolism, for blood pressure. And what we are looking at today is really the Goldilocks principle of hormones.
Right. Not too hot, not too cold, just right.
Precisely. The endocrine system relies entirely on homeostasis, on balance. When the adrenal system is perfectly balanced, you don't even know it's there. It's just humming along in the background, keeping you alive.
But the problems start when it swings to the extremes.
Yes, either hyperfunction, where the engine is revving completely out of control, or hypofunction, where the fuel tank is bone dry, and the consequences are profound.
And they are systemic. That's what's so wild. It can change your face, your skin, your bones, your mood. So the mission for this deep dive is to unpack those two major extremes. On one side, we have the overflow, Cushing syndrome.
And on the other side, the drought, adrenal insufficiency, and Addison disease.
And stuck in the middle is the modern clinician trying to balance this equation with some fairly heavy-duty pharmacology and, some real detective work.
It really is detective work.
So before we get to the detective work, the whodunit, if you will, we need to meet the cast of characters, the hormones themselves. We have two key players we need to track today. The first is the famous one, the one everyone blames for their belly fat, cortisol.
Right, the stress hormone. Although, that label simplifies it a bit too much. Cortisol is a glucocorticoid. And yes, it manages stress, but it does so much more. It regulates glucose metabolism, basically making sure you have fuel in your blood.
Okay.
It suppresses inflammation. It helps maintain blood pressure. Without cortisol, you simply cannot survive biological stress, period.
Okay, so cortisol is the general, running the whole operation. Who is the second player?
That would be aldosterone. This is a mineralocorticoid. Its job is much more specific, but equally vital. It manages the salt and water balance in your body. It tells the kidneys to hold on to sodium and release potassium.
So cortisol for energy and defense, aldosterone for pressure and volume. Got it. Let's start with the first scenario then. The engine goes into overdrive, the tank overflows. We are talking about Cushing syndrome.
Cushing syndrome. This is the clinical manifestation of hypercortisolism, which is just a fancy way of saying superphysiologic levels of glucocorticoids.
Like super physiologic. I love that word. It basically means way, way more than nature ever intended you to have.
Exactly. And the first thing we have to do as clinicians is figure out the cause. Why is the body flooded with cortisol? The sources break this down into two main categories, exogenous and endogenous.
And exogenous implies it's coming from the outside, right?
Yes. And surprisingly, this is extremely common. This is usually caused by taking steroid medications, things like prednisone, hydrocortisone, dexamethasone drugs we prescribe all the time for asthma, rheumatoid arthritis, lupus,
Severe allergies,
you name it.
These are very common drugs.
They are miracle drugs for inflammation, but they are structurally cortisol. So if you take high doses for a long time, you are flooding the body with glucocorticoids. You are, in effect, artificially creating Cushing syndrome.
Okay, so that's us doing it to the body from the outside. But what about when the body does it to itself, the endogenous causes?
That gets a bit more complex. We have to look at the control signals. Remember, the adrenals don't just decide to make cortisol on their own. They're told to do so by the pituitary gland.
Right.
And the pituitary uses a hormone called ACTH.
Okay, so the pituitary is the boss, and it's shouting ACTH, which means make more cortisol.
Right. So we categorize endogenous Cushing's by whether the boss is yelling or not. We call this ACTH dependent or ACTH independent.
Let's look at the dependent cases first. The signal is stuck in the on position.
This accounts for about 80% of endogenous cases, so the vast majority. And of those, about 85% are caused by a tumor right there in the pituitary gland.
And this is where the terminology gets tricky, because the source material makes a really specific distinction between Cushing syndrome and Cushing disease.
Yes, and it is a vital distinction for a clinician. Cushing syndrome is the umbrella term for having too much cortisol, regardless of the cause. You could have Cushing syndrome because you took too much prednisone. But Cushing disease is specifically when it is caused by that pituitary tumor overproducing ACTH.
Got it. So all Cushing disease is Cushing syndrome, but not all Cushing syndrome is Cushing disease.
Exactly. But there is another way you can be ACTH dependent, and this is where biology gets really, really strange. Ectopic ACTH syndrome.
This was the part that just blew my mind. Ectopic means out of place.
Correct. This is when a tumor somewhere completely different in the body, usually the lungs, like small cell lung cancer, or sometimes the pancreas or thyroid, starts producing ACTH.
That is wild. A tumor in your lung decides to start acting like a pituitary gland and just hijacks your entire adrenal system.
Biology can be very messy. Tumors often revert to a more primitive state, or they can produce proteins they shouldn't be able to. So the lung tumor pumps out ACTH, the adrenals receive the signal, and they ramp up cortisol production to massive, massive levels.
Wow. So that covers the ACTH-dependent cases. The remaining cases are ACTH-independent. That means the pituitary isn't shouting at all.
In fact, in these cases, ACTH levels are usually very low because the brain is trying to shut it down. It's screaming, stop. But the adrenal gland isn't listening.
Because the call is coming from inside the house.
Precisely. In these cases, there is a tumor on the adrenal gland itself, an adenoma, which is benign, or a carcinoma, which is cancer, that is just pumping out cortisol on its own accord, completely ignoring the brain.
So we have the causes. Now let's talk about what this looks like, because if I walked into a room with someone suffering from severe Cushing's, I'd notice, right, there are signs.
You likely would, yes. The clinical presentation is very distinct. The most common finding, seen in 90% of patients, is facial rounding. We call it moon facies.
Moon facies. The face becomes very round, very full, and often quite red.
And combined with that, you see a very specific pattern of obesity. It's central obesity. The weight accumulates in the trunk and abdomen, but the limbs, the arms and legs, often remain relatively thin. Sometimes they even get thinner.
Why do the limbs stay thin if the rest of the body is gaining all this weight?
Muscle wasting. Cortisol is a catabolic hormone. It breaks down protein to make glucose. So it literally eats away the muscle mass in the thighs and shoulders to fuel this metabolic fire.
There's also the famous buffalo hump.
Yes, the accumulation of fat in the dorsocervical area, so the back of the neck. But our source material makes a really interesting point here. The buffalo hump is actually, it's non-specific. Lots of people can have that just from general weight gain.
Oh, really? I always thought that was the smoking gun for Cushing's.
Not quite. If you want a more specific sign, you should look at the supraclavicular fat pads.
That's the fat right above the collarbone.
Exactly. In most people, that area, that little hollow, is concave. In Cushing's, it fills up with pads of fat. That is much more indicative of Cushing syndrome than the hump is.
That's a great clinical pearl. Okay, so we have the moon face, the thin limbs, the central weight gain. What about the skin? The notes mention something very specific about stretch marks.
Yes, abdominal stria. But these are not your typical silvery stretch marks from growing too fast or from pregnancy. In Cushing's, they are wide, often more than a centimeter, and a violent purple or violaceous color.
Why purple? What's going on there?
It's because cortisol breaks down collagen. The skin becomes paper-thin and incredibly fragile, so those stretch marks are essentially windows right into the vascular bed beneath.
So you're literally seeing the blood vessels through the thin skin.
That's exactly it. The skin is so fragile that you bruise if you just bump into a table. It's called easy bruising.
And while all this is happening on the outside, inside the body, the bones are taking a massive hit too.
A massive hit. Cortisol inhibits osteoblasts, those are the cells that build bone, and it stimulates the osteoclasts, the cells that break bone down. So it's a double whammy.
I see.
Up to 60% of patients will develop Cushing-induced osteoporosis. In fact, it's not uncommon for a patient to go to a doctor for back pain. They find out they have a compression fracture in their spine, and that's how the Cushing's is discovered.
That is just devastating. So you have a patient who comes in with back pain, weight gain, a round face. How do you prove it's Cushing's? You mentioned earlier you can't just take a random blood test because cortisol fluctuates all day.
Right. Cortisol has a diurnal rhythm. It's high in the morning to get you out of bed, and it's supposed to be very low at night to let you sleep. In Cushing's, that rhythm is completely broken. It's high all the time.
So you have to catch it when it's supposed to be low.
Exactly. So we have three main screening tests. First, the 24-hour urinary-free cortisol.
Which is exactly what it sounds like. You collect all your urine for a full day.
Every single drop. It's a bit of a hassle for the patient, but it gives us the total cortisol output for 24 hours. It's very accurate.
Okay, what's number 2?
The midnight plasma, or more commonly now, the late-night salivary cortisol. Since cortisol should be at its lowest point at night, if we measure it at 11 p.m. and it's high, that's a big red flag. It shows the rhythm is lost.
And the third one, The source mentioned something about trying to suppress the system.
Yes, the low-dose dexamethasone suppression test, or the DST. Dexamethasone is a potent synthetic steroid, much stronger than cortisol. If I give a healthy person a small dose of this at 11 p.m., their pituitary should sense it, say, whoa, we have enough steroids, and shut down all cortisol production by the next morning.
It's like a feedback test.
Exactly. So if you wake up and your cortisol's still pumping,
Then the feedback loop is broken. The tumor, wherever it is ignoring the signal.
and that confirms Cushing syndrome. Once we've established that, then we use ACTH levels and imaging CTs and MRIs to find the actual tumor and figure out where it's coming from.
Okay, so we've caught the culprit. Now how do we fix this overflow? How do we stop the flood?
The gold standard is almost always surgery. If it's a pituitary tumor, we do a transsphenoidal resection.
Which is a very fancy way of saying brain surgery through the nose.
Essentially, yes. The surgeon goes through the sphenoid sinus at the back of the nose to reach the pituitary. It's minimally invasive compared to, opening the skull. If it's an adrenal tumor, we do a laparoscopic adrenalectomy. We just take the gland out.
But what if surgery doesn't work? Or what if the patient is too sick for surgery? The source listed a whole pharmacological arsenal, and frankly, some of these drugs sound pretty heavy-duty.
They are. We generally categorize them by how they work.
Mm-hmm.
The biggest group is the steroidogenic inhibitors. These drugs literally stop the enzymes that build cortisol in the adrenal gland.
Like putting a wrench in the assembly line.
That's a perfect analogy. One of the main ones mentioned is mineralocorticoid. It inhibits an enzyme called 11-beta-hydroxylase. It stops the very final step of making cortisol.
But the source had a specific warning about mineralocorticoid. It mentions side effects related to androgens.
Right. Imagine that assembly line. Mineralocorticoid blocks the last station, but the factory keeps running, so the half-finished parts start to pile up before that block. Those precursors get shunted into a different pathway, the androgen pathway.
The male hormones.
Yes. So in women, mineralocorticoid can actually worsen acne and cause hirsutism, which is hair growth on the face and chest. So you lower the cortisol, but you create a cosmetic issue that is very distressing for the patient.
So it's a trade-off, maybe not the first choice for everyone. What else is in the toolkit?
Etoconazole.
Wait a minute, isn't that an antifungal? Like for athlete's foot?
It is. But they discovered that in high doses, it inhibits several of the cytochrome P450 enzymes involved in steroid production. So it blocks the assembly line at multiple points. It's actually quite effective.
Talk about a creative repurposing of a drug.
And it has a benefit that mineralocorticoid doesn't. It also blocks androgen production. So for women with Cushing's who have that excess hair growth, this is often a much better choice.
But it has a downside for men then.
It does. In men, that anti-androgen effect can cause gynecomastia, which is breast tissue growth and decreased libido. And a big one for everyone is potential liver toxicity. So we have to monitor that very, very closely.
It seems like every single one of these drugs has a major trade-off.
That is the nature of endocrinology. It's all about balance. There's also a drug called midotane. This falls into a category called adrenolitics agents.
Adrenolitics. Lytic means to cut or destroy, right?
And that is exactly what it does. It is cytotoxic. It actually destroys the cells of the adrenal cortex. It's basically a chemical adrenalectomy.
That sounds like the nuclear option.
It is. It's used primarily for adrenal cancer. It takes weeks to months to work, and because it stores in fat tissue, the effects can last long after you stop taking it. But it is brutal on the gut and the nervous system. Lethargy, somnolence, vertigo. It requires extremely careful monitoring.
Okay, the source also mentioned neuromodulators. These are drugs that target the brain signals.
Right, paciriotide. This is a somatostatin analog. It works on the pituitary tumor itself, trying to tell it to stop releasing so much ACTH. It's approved for adults where surgery failed or isn't an option.
And finally, there was one more drug that really stood out, mifepristone.
Ah, yes. RU-486.
Which is well known in a completely different context as an abortifacient.
Correct, because it blocks progesterone. But at higher doses, it also happens to be a very potent blocker of the glucocorticoid receptor.
So wait, it doesn't stop the body from making cortisol?
No, in fact, cortisol levels might even go up in the blood, but it stops the cortisol from unlocking the door and doing its job in the cells. It's like putting gum in the keyhole.
So the cortisol is there, but it can't cause any trouble.
Exactly. And it is highly effective at reversing the symptoms, particularly the high blood sugar associated with Cushing's.
Fascinating. So we have surgery, we have enzyme blockers, we have cell destroyers, and we have receptor blockers. Modern medicine is really throwing the kitchen sink at this.
We have to. Unchecked Cushing's leads to diabetes, hypertension, heart failure, and severe life-threatening infections. We have to bring those cortisol levels down.
Okay, let's flip the script. We've talked about the overflow, the flood. Now let's talk about the drought. Adrenal insufficiency.
The tank is empty. Hypofunction.
And just like with Cushing's, there are different ways this happens. The outline splits it into primary and secondary. Let's start with primary, which is also known as Addison disease.
Right. Primary adrenal insufficiency means the problem is in the adrenal gland itself. The cortex is being destroyed. It's failing.
And what causes that destruction?
In the developed world, about 80 to 90% of cases are autoimmune. The body's own immune system attacks the adrenal cortex. It basically treats your own glands as a foreign invader and wipes them out.
But in other parts of the world, the cause is different.
Yes, in many developing countries, tuberculosis is actually the predominant cause. TB can infect and destroy the adrenal glands.
And we also have to mention drugs again. The source pointed out that the very drugs we just talked about, like ketoconazole or metotane, can cause this if we aren't careful.
Exactly. If you treat Cushing's too aggressively, you can overshoot the mark and cause Addison's. It's a very delicate balance. Now, chemically, primary insufficiency is characterized by low cortisol, AND, low aldosterone.
Because the whole factory's shutting down. Both assembly lines are out.
Right. And because the factory's down, the pituitary starts screaming, is trying to get a response. So you see very, very high ACTH levels.
Which brings us to the most visually striking symptom of Addison's, the tan.
The hyperpigmentation. It's fascinating. Patients will look incredibly tan, bronzed even. But it's not from a vacation. You see it on the gums, the inside of the cheeks, the creases of the palms, on scars.
Why does that happen? Why does a stress hormone issue make you tan?
It all comes down to that high ACTH. ACTH is actually carved out of a giant mother protein called POMC, that's pro-opiomelanocortin. When the pituitary pumps out massive amounts of ACTH, trying to wake up the adrenals, it inadvertently produces MSH melanocyte stimulating hormone as a byproduct.
So the brain is shouting so loud for cortisol that it accidentally tells the skin to get dark.
That is a perfect way to put it. And this is a key diagnostic point. You only see the tan in primary disease.
Right, because in secondary insufficiency, the problem isn't the adrenals, it's the pituitary. The ACTH is low.
Correct. Secondary insufficiency is when the pituitary isn't sending the signal. And those common cause here is, again, exogenous steroids.
This is the withdrawal scenario we talked about.
Yes. If a patient has been on high-dose steroids for a long time, their pituitary falls asleep. It completely stops making ACTH because it thinks the body is fully stocked. If you then stop those steroids abruptly, the pituitary can't wake up fast enough. The signal drops to zero.
So no signal, no cortisol, but no huge spike in ACTH, so no tan.
Exactly. Patients with secondary insufficiency often have alabaster or very pale skin. There's no hyperpigmentation.
And usually in secondary disease, aldosterone is normal.
That is the other crucial distinction. The aldosterone system is primarily controlled by the kidneys through something called the renin-angiotensin system, not just the pituitary. So even if the pituitary is asleep, the kidneys can still keep the salt and water balance reasonably okay.
So primary Addison's patients are the ones who are severely dehydrated and craving salt.
Yes. Salt craving is a classic symptom of Addison's. They will eat salt straight out of the shaker because they're losing so much sodium in their urine, their body is screaming for it.
Okay, so let's recap the detective work here. For primary, you have low cortisol, low aldosterone, high ACTH, and hyperpigmentation.
Mm-hmm.
And for secondary, you have low cortisol, but normal aldosterone, low ACTH, and pale skin.
You've got it. Perfect summary.
So how do we diagnose this for sure? If I suspect the tank is empty, how do I check the gauge?
We do the cosyntropin stimulation test. Cosyntropin is just synthetic ACTH. We inject it into the patient.
So you're manually sending the make cortisol signal?
Exactly.
Right.
In a healthy person, the adrenals should respond immediately by pumping out a big surge of cortisol.
So you poke the engine to see if it roars.
Right. And if the cortisol level doesn't rise above a certain threshold, usually 18 micrograms per deciliter, we know the adrenals aren't working. The engine is dead.
So we've diagnosed it, now we have to manage it. And this isn't something you cure, usually. This is a lifelong management plan.
Correct. The patient has to manually replace what the body is missing. We have to try and mimic nature as closely as possible.
The source material puts a lot of emphasis on mimicking the daily rhythm.
This is vital. You can't just take one pill a day and be done with it. We use glucocorticoids like hydrocortisone or prednisone, but we typically give 2/3 of the total daily dose in the morning, right when they wake up, and the final 1/3 in the late afternoon.
To match that natural morning spike we talked about earlier to get you going?
Exactly. If we give too much at night, we'll cause insomnia. If we give too little in the morning, the patient can't function. They feel like they're just wading through mud all day.
And for the primary patients, the ones missing aldosterone, we need to replace that too.
Yes, with a drug called fludrocortisone. It's a mineralocorticoid. It helps them retain salt and water and maintain their blood pressure.
Now, here is where it gets really, really important. The stress dose rule. This feels like the most critical piece of education for any patient with this condition.
It is the difference between life and death. In a healthy person, if you catch a fever, broke a leg, or even just go for a really intense run, your body automatically spikes cortisol to handle that stress. It might go up 5 or 10-fold.
But if you have adrenal insufficiency, your body can't do that. You have a fixed amount of pill in your system, and that's it.
Right. You're driving a car with no shocks.
Yeah.
If you hit a bump, the axle breaks. So patients have to be taught to be their own endocrinologist and adjust their own medication.
They have to be their own doctor in those moments.
They do. The source suggests adding 5 to 10 milligrams of hydrocortisone before strenuous exercise. But the big one is the sick day rules.
Okay.
If you have a fever over 100.4 degrees Fahrenheit, you double your daily dose of steroids. You stay on that double dose until you're completely recovered and fever-free.
Why double? Why is that so important?
Because the metabolic demand of a fever is massive. Your body is under incredible stress. If you don't provide that extra cortisol, the blood pressure will crash, your blood sugar will drop, and you will go into shock.
And if they don't do that, or if they have a major accident and are unconscious and can't take their pills,
Then we enter the danger zone, acute adrenal crisis, also known as an Addisonian crisis. This is a true endocrine emergency.
what does that look like? How would you recognize it?
It looks like shock. Profound hypotension saw, very low blood pressure that doesn't respond well to just giving fluids, severe abdominal pain, nausea, vomiting, confusion, fever. They can die very quickly from vascular collapse.
The source mentions the trigger is usually abrupt withdrawal of steroids or a major stress event in someone with an undiagnosed condition.
Exactly. The treatment must be immediate. We don't wait for lab results. If a patient with known Addison's comes into the ER looking like that, we treat first and ask questions later.
And the treatment is?
IV hydrocortisone. A big dose, 100 milligrams, is a bolus immediately. That single dose covers both the glucocorticoid need and, at that high level, the mineralocorticoid need. And at the same time, we pour in fluids 5-E dextrose 5% in normal saline.
Why the dextrose, the sugar?
Because without cortisol, these patients are often severely hypoglycemic. Their blood sugar is dangerously low. We have to support the pressure and the sugar simultaneously to pull them back from the brink.
It really emphasizes how fragile this balance is. You take away these tiny glands, and the whole system collapses under the slightest pressure.
It does. That's why the source emphasizes the safety net. Medical alert bracelets. Every single patient needs one. It should say adrenal insufficiency, steroid dependent.
And the injection kit.
Yes.
Yeah.
They should carry injectable hydrocortisone with them at all times. Imagine you get the stomach flu and you are vomiting. You can't keep your pills down. But your body is under incredible stress, so you need more steroids, not less.
That's a terrifying catch-22.
It is. So they have to be taught how to inject themselves in the thigh immediately to buy time to get to the hospital. It's their lifeline.
That is a heavy burden to carry, knowing you have to manually regulate your own stress response every single day.
It is, but with proper education and adherence, these patients live full, normal lives. The key is monitoring. We watch for the tan to fade in Addison's patients. That's a good sign the treatment is working.
And if they start getting a moon face and a buffalo hump,
Then we've overshot the mark. We've given them iatrogenic Cushing's. We adjust the dose down. It's a constant, lifelong process of fine-tuning.
So let's unpack the big picture here. We've looked at the overflow and the drought. We've seen how tumors, immune systems, and even our own medicines can throw this delicate balance way off. What's the main takeaway for someone listening to this?
For me, it is the vital importance of the taper. We mentioned it in passing, but it really bears repeating. We live in a world where steroid medications are very common.
People take them for back pain, for poison ivy, for, a bad sinus infection.
And people often stop taking them when they feel better, or they think, I don't want to take this chemical anymore, I'm done.
Which is just about the worst thing you can do.
It is incredibly dangerous. The source material is clear. The HPA axis, that communication between the brain and the adrenals, can take weeks, sometimes months to wake up after being suppressed. If you stop abruptly, You can plunge your body into an adrenal crisis.
So whether you are coming off medication or managing a lifelong condition, patience and gradual adjustment are absolutely key.
It's everything. You cannot shock this system.
It really makes you appreciate the autopilot function of a healthy body. We don't have to think about releasing cortisol when we run for the bus. We don't have to calculate our aldosterone when we eat a bag of salty chips.
It's a silent, perfectly orchestrated symphony happening every second of your life. Until it isn't.
I want to leave the listeners with a thought that really stuck with me from the source material. We talked about ectopic Cushing's, how a tumor in the lung can release a hormone that completely changes the shape of your face.
Yes.
It's just such a profound reminder of the interconnectedness of the body. You can't compartmentalize these systems. A problem in the chest becomes a problem in the skin, the bones, the blood sugar, and the brain.
That's the beauty and the terror of endocrinology. Everything touches everything else.
Well, on that note, check your stress levels, appreciate your adrenals, and we will see you on the next deep dive.
Stay balanced, everyone.